All set.
Then
So this is
all set. Okay.
Who Richa is presenting, is it? Richa, and who's the other presenter?
So I'm Pratik.
Okay, and where are you all from?
So I'm from HCG Cancer Center, Ahmedabad.
Okay.
I'm from AIMS Jodhpur, sir.
Oh, lovely. Dr. Dev, some of our youngsters in DNB also wanted to present here. So just tell me, how do they apply to Subbu?
No, sir, we can. No, sir, you send us the names. We will
Okay.
involve them in the next session. Not a problem.
Done.
Definitely.
Okay,
definitely.
great.
Just send the names to us.
Yeah.
So we have every fortnight. So we can involve them in the next cases, sir. Definitely. Not a
Done.
problem.
Thank you.
Welcome, sir. So we have 1 minute to go. Fani, you are ready?
Yes, sir. Sir, we have an added lamp lighting and inaugural ceremony, which sir has requested you to take over at that point in the initial part.
Yeah, so I will be just giving a brief welcome address. That's
Yes,
all.
sir.
So we'll
There will
start
be a
the-
lamp lighting at the same time, following which you can introduce the examiners.
Yeah. So Dr. Rao will join?
Yes, sir. Sir is just on the way.
Fine. Good evening, Dr. Rao.
Good evening, President sir.
Oh, sir. Good evening.
Good evening.
You're all waiting for Dr. Rao.
Good evening, President sir.
Namaskar, Dr. Rao.
Namaskar, past President sir.
And
Anil, good evening. Arvind, good evening.
But
Subbu, good evening.
Good evening.
have you really come from the operating rooms, the two of you all, or you'll have dressed up for the evening? Huh?
I've learned everything from you, but to be a doctor, but not an actor, Anil.
Hello.
Well, sir. I think, Funny.
Good evening to everybody.
Good evening, sir. Good evening, Dr. Das.
Good evening to everybody.
So it's 7.
7.
Shall we start, Dev sir?
Sir, definitely. We can start.
Yes.
So, are we live?
No.
Yes, sir, we are.
We are?
Yeah, we are.
Live. Yes.
Live, sir.
Fine. So, very good evening to all of you. On behalf of IASO, I would like to welcome everyone for this first inaugural masterclass of IASO teaching series of 2024. So we have taken a break after the last year and starting with the new session of masterclasses, which are very popular. And we are starting with the topic of oral cancer, the most common cancer. And we have very eminent examiners today with us. Can I have the slides, Funny? So these masterclasses examiners, we have a moderator, we have an expert. This is a 2-hour session. The first topic is oral cancer 2. Why we have called it 2 is we have already done one oral cancer session 3 years back. So it is a revisit. So we will be covering broadly all aspects and also update any recent advances which have happened in the field of oral cancers. So we have 2 examiners with us, very eminent and reputed examiners. Dr. Anil De Cruz needs no introduction. He is the Director of Oncology for Apollo Hospitals and ex-UACC President. He is one of the most renowned head and neck surgeons. Along with him, we have Dr. Arvind Krishnamurthy, who is the Professor and Head of the Department of Surgical Oncology at Tadiyar Cancer Institute. So these 2 will be acting as examiners. And we have moderator Dr. Shiv Kumar from Tata Memorial Hospital, Mumbai. So he will be moderating the whole session. And there will be a chief guest and expert talk by Dr. Anil De Cruz. And we have 2 young, bright students, Dr. Richa Todi and Dr. Pratik Gautam as examinees. So both of them have actually won the IASO awards during the recently held ICC conference at Mumbai, and they presented abstracts on behalf of IASO at a recently held SSO USA. So I welcome you all for this inaugural IASO masterclass session for 2024. We can start the scientific sessions now. So these are our awardees, Dr. Richa and Dr. Anil, yeah. We can start funny, yeah?
Yes, sir.
Please.
Dr. Dev, you should have welcomed to both the examinees, but you should have told us they're so renowned. We would have read a little bit, Arvind and me.
Sir, they will give us a real tough time, both of them.
Yeah, okay. Good luck. Let's start.
Thank you, sir.
These are the instructions for the session. The examinees are requested to kindly give answers to the point. Everyone is not expected to know all the answers, so it saves time if you say that you do not know, and it maintains the flow of the exam. Examiners keep giving hints, and it would serve you well to kind of pick them up. The moderator is requested to kindly address the examinee by the name to whom the question is directed to avoid confusion and to ensure both get equal opportunities. And the examiners, in the interest of online viewers going on live right now and in YouTube, are requested to kindly give the expected answers to the questions that are unanswered or incorrectly answered. For the participants, senior IASO members and faculty are requested to kindly post your inputs in the chat box, and the residents, this is a unique opportunity to clear your doubts, so fire away.
So I would like to thank Dr. Rao for organizing the entire first masterclass, and Dr. Srijan, who could not join today. And I'm happy to say that there's already 100 logins for this class already, 103 right now. So it is going to increase, I think, in another 10-15 minutes.
I request Deo sir to take
Okay.
over.
Yeah, sir.
So what should I do? Funny?
It's
So,
a virtual lamp lighting, sir.
By
so you want me to
the
click?
chief guest, Anil De Cruz. So you should be conducting this part.
So
Dr.
what?
Anil, please.
Let's do it. Let's do it together,
yeah.
Dr. Dev. Like we
Sure,
hold
sir,
hands
please.
when lighting the lamp.
Sure.
Here goes.
Great. So this lamp was lighted by Dr. Anil. This was by me. Dr. Rao, sir, please join us. You are the master behind the master classes.
And message by Anil De Cruz, the chief guest.
You want me to say a few words?
Yes, please.
Please,
So
please.
this is the inaugural
Inaugural
session
class,
of the.
first one.
So good evening to all leadership of the IASO, all delegates, other senior members of IASO, and the two examinees. I'm delighted and must congratulate the leadership of IASO. I have seen a distinct change in IASO. I've been one of the members for more than 20, 30 years maybe, and I've really seen a distinct change in the way the IASO meetings have conducted, the emphasis on academics, the emphasis on nurturing youngsters. And I always say, I wish I was born 30 years later to get full use of what's going on. So all youngsters who have today logged in, you have to thank the leadership for giving you all such a good opportunity to enrich your knowledge. I always, when I speak to youngsters and even to faculty in our country, I always say times have changed. When I grew up, there was a big divide between the East and the West. We followed what the West did and we followed blindly. Times have changed. And I have a beautiful slide. I would have put it up showing the number of publications coming out from our country. And I must say, it makes me very, very proud. And it's not from one or two academic institutions, it's across the country. I'm now on the ASCO board and had the opportunity to review the ASCO abstracts this time for head and neck. I must say there were at least 10 from our country, and all from different institutions, some from small institutions from Nasik and other things. So I'm going to be brief and say that I want our youngsters now to please give us international leadership in oncology. At least in head and neck oncology, this is our cancer, and you all can do very, very well. So happy learning in the next session of this IASO masterclasses. Congratulations once again to the leadership. And we look forward to something very interactive today. And hopefully this trend will continue for the whole year of classes. Thank you very much for giving me the opportunity to share my few thoughts with you all today.
Thank you. Thank you. Thank you, Dr. Anil. I would also like to welcome Dr. Toprani and Dr. Das, our ex-leadership, who have played a very big role in the popularity or bringing together these master classes. Dr. Arunab will join shortly. So we can start this session, Funny. Dr.
Yes.
Rao, sir, is it okay? We can start now?
Yes, yes, by all means, yes.
Yes, please.
I request Dr. Shivakumar, sir, the moderator for the mock examination session, to take over and start the exam.
Thank you. Good evening to all. And I would at the outset like to thank IASO for this opportunity. So let's straight away go into the case. Do I have the control of the slides, or how do we go about it, Funny?
You should have controls.
Yeah. At present, I do not have it.
Okay, sir. I'll just go to the next slide.
Can I present the slide from my laptop?
Yes, sir, you can.
Because otherwise it will be too many. I'll just share it in a moment.
Yes, sir.
Is my screen visible?
It is.
Right. Thank you. So we'll proceed with case 1. So this is a 50-year-old gentleman. He came with complaints of non-healing ulcer on the right side of the tongue for 4 months duration. It was associated with non-radiating pain. He gave history of using tobacco, smokeless tobacco, for 25 years and presently reformed. He's a known case of hypertension on medications. So over to the examiners if they want to, ask any further questions to the to reach Dr. Richa or Dr. Pratik on the clinical information so far given.
So youngsters, quickly tell me, why did he highlight on this non-radiating pain?
Sir, because radiation of pain can be seen to the external ear because of common sensory supply. The lingual nerve, which is the sensory supply of the anterior 2/3 of the tongue, along with the chorda tympani, which carries the taste sensation that relays in the otic ganglion from where the auriculotemporal nerve arises, and which supplies the external ear. So the pain from the anterior 2/3 of tongue can be relayed to the external ear.
Excellent.
So, Dr. Richa, or any other subsite in the oral cavity can give similar pain, or is it only?
Yes, sir. Buccal mucosa also can give, floor of mouth also can give referred pain to the external ear. And if the lesion is arising from posterior third of the tongue, the referred pain will be to the middle ear, so, because of involvement of tympanic plexus.
Right. No, referred ear via the auriculotemporal.
Yes, sir.
Any other subsites? You rightly mentioned tongue, floor of the mouth. Can it be any other subsites? Could it be salivary glands itself? Could it be alveolus? Is it only the lingual nerve, or is it any other nerves also can
glossopharyngeal?
Glossopharyngeal, as you rightly said, is for the
middle ear.
Middle ear.
Posterior.
It's a
Yes.
dull aching middle.
Okay. So as you rightly said, I think it could be anywhere. The tongue, the buccal mucosa, alveolus, even salivary glands, similar sort of radiating pain may be there, but of course in this case it's not there.
Okay, Richa, before you jump, quickly one point on pain. How does the base, or where clinically is the base tongue pain different from anterior tongue pain? Where will the patient point? Look at think of the efferent nerve of both pathways and tell me where the pain would be.
Anterior tongue, they will point to the external ear, and posterior tongue, they will point to the middle ear, sir.
So, okay, it's very simple for all the, so the anterior tongue is auriculotemporal. It will be in front of the ear, in front of the tragus. At the base of tongue, it will be tympanic nerve, tympanic plexus. It will be inside the ear. And if you have in the supraglottic larynx, it will be Arnold's nerve, which is behind the ear. So whenever you take history, ask them dard kidhar hota hai. If they point inside the ear, put your Hopkins scope and look at the base of tongue. Okay, good.
Right. So let's go with the clinical examination. On examination, the patient had good mouth opening. There were no sharp tooth. Patient did not have ankylosing. The lesion was on palpation, it was well away from the midline. The base of tongue and floor of mouth were free. There were no other lesions that were visualized in the oral cavity. On the examination of the neck, there were no palpable nodes that were there. So, any questions subsequent to the examination? I think we can start with Pratik for that.
Yeah.
Yeah, questions from the examiners to the examinees. Pratik can take the question.
Okay.
Yes,
What
sir.
about ankylosing, Pratik? I think, can you sort of, because there has been some change that has happened over the years with reference to our understanding. Can you just briefly define ankylosing and maybe in the staging systems, what sort of change has happened with regards to ankylosing?
So the fixity of the tongue, the ankylosing refers to the fixity of the tongue. It could involve it could mean a floor of the mouth involvement that might be restricting the mobility of the tongue. Sir, regarding the recent change in the AJCC guidelines, the depth of invasion is taken into consideration for the staging. So if the floor of mouth is involved, then the depth of invasion is will be more. So the cancer will be an advanced stage cancer. So.
Yeah, previously ankylosing was considered as possibly referring to an advanced cancers, but it's more towards the depth of invasion.
Not more towards the depth.
Okay, Pratik Richa, what has he missed in this examination?
So the indurations surrounding the ulcer? Or
No,
the
I think this is only inspection. I don't know if he's done it. Okay, he said no palpable nodes. Do you want to check any nerve here when you have a tongue lesion?
hypoglossal nerve?
Yeah, so that should always be part of your examination. Which side does the tongue deviate?
To the same side of the
Ipsilateral side.
Good, excellent.
What other lesions in the oral cavity do you look for? Like
oral potentially malignant lesions like leukoplakia or oral submucous fibrosis.
so, would you expect anything considering that he has had?
He's a tobacco chewer, yes, sir.
Right.
He can have a oral submucous fibrosis, but the mouth opening here is adequate. So.
Okay, I'll just jump in here. When you said mouth opening adequate, how do you know it's adequate?
Say good mouth opening.
No, he said good mouth opening. So what happens? Is there any staging you know for
Yes,
mouth
sir.
opening, or if a ladu goes in, it's good mouth opening?
Sir, it should be minimum 3.5 centimeters, the inter-incisor distance.
Excellent. Whose classification? Whose classification?
The Broader's classification.
Broader's, is it? Shiva's shaking his head so vociferously when you said borders.
No, sir.
Broader is for what?
Broader is for differentiation.
Differentiation, yeah. Broader is for differentiation.
So the commonest classification that we use is by two. It's an Indian classification, came from Nair Dental and pretty popular among our Indian examiners. It's called Khanna and Andrad. Dr. J.N. Khanna and what's this girl's first name? Andrad. She's the head, Neelama. She's in the Nair. So please read that classification. I'm not going to waste time. You all must know one classification. There are at least 10, but at least know one.
Right. So, I just would like to ask Pratik as to, it's mentioned there's no sharp tooth. Is there any relevance to this?
Sir, sharp tooth can cause injury to the tongue, and chronic irritation and inflammation can cause a malignancy. And that might be leading.
Is there any evidence to suggest that, poor oral hygiene could be associated as a risk factor to oral cancers?
The evidence I'm not aware, but alcohol, the patients who take alcohol, the alcohol is converted to acetaldehyde by the organisms in the oral flora. So that can cause chronic irritation and inflammation that can cause cancer. So I don't know any evidence, sir. I'm not aware.
No, it's a separate risk factor, right?
Yes, sir.
Tobacco is one, alcohol is one.
Alcohol
And
is-
incidentally, earlier it was believed that it was separate. It was alcohol is a cofactor, but there is now evidence to suggest that it is independently associated with oral cancers. But with specific regards to sharp tooth and poor oral hygiene, there are a couple of meta-analyses that suggest that there could be an increased, it could be a risk factor for development of oral cancers. Any other risk factors other than this? Like, can you?
So syphilis is known to cause oral cancer, but we have not seen nowadays. And then
Let me be a little more specific. Is lichen planus causing cancer? Is HPV causing oral cancers?
Yes, sir.
Yes.
Quote what you can quote to support. HPV causes oral cancers?
More oropharyngeal, sir.
More of oropharyngeal
Evidence
cancers.
for oropharyngeal cancer.
Richa, you're a gold medalist. That we all know it's oropharynx. I'm asking you oral cavity. I'm not going to waste my time on the evening asking you whether oropharynx is caused by HPV. Oral cavity, tell me, is there any data? Can you quote a meta-analysis? Okay, it doesn't cause. There is an increased incidence probably attributable to HPV. One of the meta-analysis is Oral Oncology 2015. Newell Johnson is the last author, saying there's insufficient data to attribute oral cavity cancers to HPV. But because they don't know the E6, E7, the mRNA, but if you just sample for HPV, 36.5% of Asian populations will have HPV. But whether it causes is unknown. And exactly the same for lichen planus. In the old days, lichen planus was considered pre-malignant, but the incidence is very, 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 very low. So now they say if you have lichen planus with other factors, and there are at least two meta-analyses that Vakala, Surya and all have done in 2018 Oral Oncology, they kind of show that if you're a smoker, female, those kind of using alcohol, you do have a higher incidence with lichen planus, but both are not taken as very strong pre-malignant or potentially malignant conditions.
Right.
Like, so just to add on, like, HPV, I guess, there are some papers which actually challenge the presence of HPV as a risk factor also. But I think some suggested that the association could be in single digits, like, for oral as well as supraglottic laryngeal cancers as well. Like, so that's what I wanted you all to sort of, mention, at least with regards to HPV. Yeah, there is a lot of controversy, as sir said. See, if at all, it's very unclear, the association. If at all, the association would be there barely in single digits in majority of the series. But there's a lot of heterogeneity with regards to the data.
Right. So I think we'll move on to the...
So any clinical staging you can give for this patient based on this, Dr. Pratik?
So I think it's a T2N0 lesion. Clinically, it appears to be.
Right.
As per the size, it will be T2 probably. So I can't see the posterior extent, but
what else do you require?
So the depth of invasion. So this is more of an exophytic lesion than an infiltrative lesion. So
you don't know, right?
No, sir.
So you would, what do you want to sort of, comment? Like, would you sort of comment it right now, or would you say that you want something?
I want to palpate the lesion digitally, and see whether the how much is the depth of invasion I would like to see, and the posterior extent and the exact size of the lesion, so that I can stage it accurately clinically.
Yeah. So does radiological inputs come in clinical staging?
Yes, sir. Radiological, it's actually clinico-radiological staging that will help us diagnose it
So
better.
you're right that you need to know the size, you need to know the clinical depth of invasion. Also, you need to know some radiology. And what can you make out? Can you make out depth of invasion and radiology?
Yes, sir. MRI for tongue cancers, MRI will be a good radiological investigation to see the depth of invasion.
Can you make can radiology tell you depth of invasion, Dr. Richa?
Yes, sir.
Huh?
Yes, sir. We can measure the depth of invasion.
So it can actually show it will actually show the third dimension, that is the thickness of the lesion. The actual depth of invasion will be a pathological depth.
Right. So thickness would be actually seen in radiology.
Radiology.
It could be a very close associate. And you are aware of the difference? Anybody can quickly tell, and so that we can proceed between thickness and depth of invasion.
So thickness is from the mucosal surface of the tumor to the point of deepest invasion, and depth of invasion is from the surrounding basement membrane of the surrounding adjacent normal tissue to the deepest point of invasion.
Perfect. I think it's very important. Yeah, please go on, Shiva. We can see it.
So with that clinical information, we'll just move ahead to the workup for this patient. So first being biopsy. Any particular question on biopsy, and then we'll go for imaging?
My favorite, very simple MS question. Where do you take the biopsy from?
Dr.
The
Richard?
edge of the ulcer, sir. A wedge biopsy or a punch biopsy from the edge of the ulcer.
Why do you take it from the edge?
Because the proliferative index is high at the edge, there will be less chance of getting necrotic material. Plus, we can take normal mucosa along with the biopsy for the pathologist to compare the normal and the abnormal.
So when you take normal, do you have to give local anesthesia? Who does local anesthesia for biopsy? I'll tell you someone in 1950 said do a biopsy from the edge, and you fell into my trap. The edge ulcer is only done for chronic ulcers, tuberculosis, syphilis, to see the zone of transition. There are 3 zones in an ulcer that's chronic. In a oral cavity cancer, we take it from the most representative area, avoiding necrotic areas. And I always punch in the middle or on the side. It's so easy to get a bit. I want the examiners, other two, Shiva and Arvind, do you all take normal tissue? Unless it's verrucous, knife biopsy, we take a punch biopsy. Why you're saying knife?
See, in this patient, in the picture that was shown, there is no necrosis as such. Sometimes you're right. Sometimes you have an ulcer with a necrotic component, in which case you may want to punch from the slightly periphery. But in this case, it's an OP procedure. You can just do it in your examination cubicle itself, punch, and you will be able to get the diagnosis. I agree. I think so.
Yeah. I just
okay. Yeah, go ahead, Shiva.
The reason why Richa said that, maybe that many times we see lesions which are verrucous kind of lesions.
Verrucous is different. Verrucous is different. You have to take not the edge. You have to take the deep stroma. It's not the edge. So even if you say in verrucous, the reasoning is different. Richa, what's the role of brush cytology in this? I don't want to biopsy. I want to do like a pap smear on this. Brush cytology. Role of brush cytology.
I'm not aware, sir.
Huh?
I'm not sure, sir.
Pratik.
So brush cytology in this lesion, sir, it is not warranted. You should take a punch biopsy with a good amount of tissue, and it should include the basement membrane, sir, to get a better idea.
I'm with you, my friend, but this is squamous carcinoma, cervical cancer squamous carcinoma. Why do you do a brush or a pap smear in cervical, and why do you here not say that brush works?
I do not know, sir.
Arvind will answer the difficult questions, or Shiva. Because the exfoliations of cells here are less than in the cervix. This is a keratinizing squamous carcinoma. So you don't get a good yield. But Dr. Shubhda Kane and others who were part of our used to do with a toothbrush and take out some cells. So sometime. But generally in oral cavity, it's always a punch biopsy or a knife biopsy, as Shiva said.
Right. So next, moving on to imaging for local regional evaluation of this tumor. the question that can be asked is what would be the preferred
Yeah.
imaging modality?
You did mention briefly earlier, but you would want to elaborate the choice of imaging or the need for imaging first.
Shiva, if I may just request you, rather than you lead them, I think they should tell us what imaging they'll do. Don't give them options.
Sure.
Let Richa say, then let Pratik say whether he agrees, disagrees, do something else, and then Arvind and me will launch into them.
Sure, sir. We'll do that.
Go ahead, Richa. How will you work up this patient imaging?
Sir, I would like to do a contrast enhanced MRI of the tongue.
Okay. Pratik?
So yes, I would also like to do the same contrast and MRI. It will give me the local extent and the nodal status as well.
So I'm asking you a question. I want to do a PET scan, right or wrong? And I'll give you my reasons. I'll see the local tumor and I'll also see distant metastasis. It'll be a one-stop shop.
So this is an early cancer. And so as per the guidelines, it's not warranted PET scan, but we can do a PET scan. It is if we
let me say the ulcer is 3.2 centimeters, slightly locally advanced, one small node felt there. Now will you do a PET or will you still do the MR?
So I'll do the MR and a CT thorax for the chest, sir.
I'm saying do PET, one test. No, why you want to do two?
MRI is a soft tissue delineation, sir. We can tell the exact depth of invasion and the local extent of the tumor better, whether it's involving the base or crossing the midline.
Very good.
It's better seen on MRI.
And even the neurovascular involvement will be better seen in the MRI, sir.
So the answer you have to give is that the incidence of metastasis is low in this. My spatial resolution is much better with the MRI because of soft tissue, and I would prefer that to PET because it will guide my resection.
Right.
That's the answer. Okay, great. I agree with you all. Go ahead.
Right. Dental evaluation and any other investigation apart from these. I mean, open for questions from the examiners to both the examinees.
So when do you do a PET CT, like for evaluation, Dr. Pratik?
Sir, larger lesions like T4A, T4B lesions, and sir, if any, there are neck nodes that are in the palpable neck nodes. And when we suspect any distant mets, we can guideline suggest, sir, for grade 3 and grade 4 locally advanced tumors, we can do a PET scan. Stage 3 and stage 4 tumors.
Any other reason why you could do a PET scan, Dr. Richa?
So when there are bulky nodes and the nodes are below the level of the thyroid cartilage.
Multiple nodes, bulky nodes, lower level nodes.
Lower levels, yes.
So let me just jump in here with an answer. The examiner wants an answer. A CT of the chest is adequate because the majority of head and neck cancers metastasize to the chest, particularly oral cancers. I will only do a PET scan, sir, when I suspect distant metastasis. One is when it's N3 nodes, lower level nodes, and there's one more reason in head and neck when you do it. Can you tell me?
Recurrent cancers?
No, I'm talking about primary, de novo. I'll give you a clue. Which subsites metastasize outside the chest? नाक के पीछे क्या है? Nasopharynx, distant metastasis. Pyriform fossa, distant metastasis. So there are three indications: large nodes, bulky nodes, and when it's nasopharynx or pyriform fossa as the site of the primary.
Maybe there are just two other things also. Supposing you are trying to do some sort of a heroic surgery, like for example, it's a T4B and multiple neck nodes, and if you are confident that you are able to get an R0 resection, then in such a case, maybe you may choose to do a PET CT just to rule out a distant metastasis because the propensity of metastasis is pretty high. There's also another subset. I think it's not common here, but sometimes HPV associated cancers, the locally advanced ones, tend to sort of metastasize in organs other than the chest as well. Of course, it's not truly relevant from the Indian subset because our incidence seems to be slightly lesser. But that is another, of course, it doesn't come under the purview of oral cancers. But when we discuss about PET-CT, we must sort of, discuss this. And there is also another role of PET-CT. Any evidence that you can say, any study at least rather, that you can say for PET-CT to suggest or to study your N0 neck? Since you're answering very well, I thought you could sort of, it's just a study. Of course, it may not have a great clinical relevance, but any of you, Dr. Richa or Dr. Prateek?
Put it a different way. How do you image the neck? Is PET a good investigation to image the neck? Forget putting the study.
Yeah, right. For occult lymph node metastasis, that's what the question is.
Sir, it is found to be more sensitive than CT and MRI in detecting occult nodal metastasis, but it's almost similar. Like there's no significant, but it might help to change the plan in some 20-22% patients. Sir. I'm not exactly sure about the study.
I think you've quoted the results of the study. I think
Yes,
it's Akron 6685, but it's just that what you said is right about the study, but it's almost similar to CT scan with regards to sensitivity or accuracy for nodal metastasis, and it's not something that we routinely do in practice. Yeah.
Right. Shall we move on?
Yeah, sir.
Yeah. Right. So the biopsy of this lesion was reported as moderately differentiated squamous cell carcinoma. We did imaging for the local lesion evaluation using an MRI, and these are the representative pictures for you to comment on. Over to the examiners for questions on these.
If I gave you a choice of looking at one image, what sequence would it be to see the best delineation of the tongue lesion?
T2 coronal image.
No.
T2, sure.
T1, sir. T1 fat suppressed, T1.
I might give my vote to Richa this time, Prateek. She'll get the ticket to the US. A T1 with contrast, probably fat suppressed, would show you the best. Whether it's coronal or axial, they both have different information that they give you. One gives it to you this way, one gives it to you that way. So you need both.
Yeah,
but it's usually T1 with contrast fat suppressed.
And that is exactly what is being displayed here. T1.
Correct. And T2 tends to sort of overestimate at times. So I guess it has to be T1.
Are Prateek and Richa, he says that this is T1. How do you know whether he's telling us right or he's bullshitting? How do you know this is T1?
So the size of the lesion looks less than 2 centimeters.
Any other anatomical structure?
The tumor thickness and depth of invasion also looks less than 5 mm.
Nain, you're not answering my question.
So the spinal cord is
that's
cerebrospinal fluid is dark in color, so it's a T1 image.
Very good. That's the answer that you should do. It's either the cerebrospinal or you'll see the eyeballs well.
Eyeballs.
Yeah.
Okay.
So I think the ticket is for Prateek now.
Okay, go ahead.
Yeah. So the staging, I mean, it's put it this time around. So I think Prateek was right to begin with, and now I think it's clinical radiologically T2, N0, and M0. We have done the CT thorax. I mean, chest X-ray is what we would usually do for an early lesion, and CT thorax was not done for this case. And so the question regarding the treatment, examiners, should I go? We can just one point at a time. We have 5 questions listed.
Okay, go ahead. Question quickly. Surgery or radiotherapy?
Surgery, sir. Upfront surgery.
Sir.
But RDR always does radiotherapy first, right or wrong? No, Arvind, I'm just having fun. Don't get upset. Right or wrong?
Wrong, sir. So surgery will be the first choice here in this case, sir.
Why you said wrong? Tell me why are they wrong?
Sir, they're not wrong, sir. There is an option of radiotherapy, but in this case, I would like to tongue cancers are so they are very notorious cancers to recur, and I would like to reserve radiotherapy for a second if patient develops a second primary or.
Shiva, go back to the image on top. To me, they are wrong with if they're doing radiotherapy. Look at this and tell me why.
So because the lesion is in close proximity to mandible and there are risks of osteoradionecrosis.
Very
also.
good.
Right.
Any other? So what's the ideal lesion if you have to give radiotherapy or brachy?
Say T1 lesion on the lip or.
No, my friend, what's the ideal lesion for tongue? Mujhe theory nahi dena. I'm asking specific to the case she was presenting. For tongue, what is the ideal lesion? Don't tell me I'm not going for MD radiotherapy, so I don't know the answer.
So maybe on the dorsum of the tongue,
Dorsum
away
of the
from the
tongue.
bones.
It should be less than 3 centimeters. It should be superficial. It should be away from the bone. It should be easily accessible, and the patient should be able to take anesthesia. 5 indication, cut, bologe, examiner will go to the next question. Richa, repeat what I said.
So it should be a superficial tumor less than 3 centimeter in size at an accessible site. Patient should be able to undergo anesthesia.
And it should be away from the bone.
Away from the bones, yes.
Anything else, Arvind? You are the gold medalist. Tell us anything else? No.
No, the thing is that, we operate such lesions for many years now. That is the only other thing.
No, I'm just kidding.
The other thing, any other, in terms, there are two ways in which you can answer this question. One is in terms of oncological outcomes. The other in terms of, many other factors. So I just want you all to sort of, answer this question, surgery or radiotherapy from that perspective. Of course, proximity to bone, obviously you can't see it because you saw the clinical picture. This lesion was not close to the bone, right? It was just much away from the bone. So in terms of oncological outcomes between surgery and radiotherapy, is there anything you want to add?
So
because if you see the NCCN guidelines or any other guidelines, they would sort of, give you both the options. I'm just trying to play the devil's advocate. I'm not trying to sort of, push for radiotherapy, but I just want you all to have a better comprehension of this.
So for T1 lesions, they have similar, but surgery still has slightly better advantage compared to radiotherapy. But,
so any study, anything that you want to sort of say to suggest its superiority of surgery? There are randomized control trials. There are large NCDB meta-analysis as well.
The NCDB meta-analysis, sir, that I have read.
More than 20,000 patients. Yeah.
But,
and the other aspect favoring surgery?
So we get a histological information about the tumor, the prognostic factors, whether there was LVI, PNI and stuff. So we can prognosticate whether there's chances of recurrence of tumor is high or not.
So again, it's quick, it's accessible. It can be done. It can be repeated if at all. We keep radiotherapy for reserve. You have to address the neck, which can be done in the same setting. So all these things are all there for surgery. Yeah. And what type of surgery would you do?
So a wide local excision with a 1 centimeter margin and primary closure for this lesion.
And complete, okay.
With
an
IASO, with a selected section level 1 to 4.
1 to 4. 1 to 4.
Yes, sir.
Why?
Let me just stop at the margin. You said 1 centimeter. Supposing it comes as 8 millimeters, will you be sad?
No, sir.
No,
it's,
sir.
7 millimeters, will you be sad?
No, sir. It's like we are taking the shrinkage of the tissue into account post.
No, my girl. When the report comes, it's 6 millimeters. Have I spoiled the case? Because you said
sir.
No, sir.
More than 5 mm is clear margin, sir.
So why don't you answer differently and tell the examiner that I will aim for a margin which is at least 5 millimeters I allow for shrinkage, and I will place my knife 8 to 9. If it's at the tip, you don't take out 1 centimeter. You'll functionally screw up the patient. So you should take minimum of 5 millimeters. That's the margin. That's the answer you should give. Otherwise,
Yes.
ask you why not 1.2, why not 1.4, why not 8 millimeters? So let
Right.
him understand that you know the literature well. I'll show you a slide when I speak, if people are still logged in when I have to give my talk.
What
Okay.
about frozen section? Then
Will you do frozen? Yes, no.
So
If facilities
Huh?
are available, we can do a frozen section for margin control.
what is the rationale? What is the evidence? Now, again, so if the facilities are not available, what?
So like if the margin comes positive, we can re-excise in the same surgery in case we have done a frozen section control. So
Do
So-
they do
Has
frozen
it-
for all cases in your institution?
no, sir, we are not doing for all cases. Post NACT cases, we usually do.
So then why are you answering that if it's available, I can do it? Why you're getting into trouble?
So,
Pratik?
No, sir, I will not do a frozen section because, sir, a large-scale study of around 1,400 patients from Tata Memorial Hospital, it has showed that there is no benefit of doing a frozen section for.
Is there any meta-analysis which is global?
2019. Mustafa Bulbul.
Mustafa Bulbul paper, sir, yes, sir, on margins. That
What
also
did it
shows
say?
no. So it shows no survival advantage of doing a frozen section.
No, it says that frozen sections, there's insufficient data to conclude that it is useful, and they want us to do more studies. So in the exam, your answer should be, there is no conclusive evidence, sir. If I've operated with wide margins and I don't have, I will accept it. However, if I feel my margins are compromised, I may send it for frozen if I have the facility so that I can revise at the same sitting. That's how you should answer. There's no right or wrong answer. The examiner wants to know whether you all understood the literature. That's what they want. So MCH is giving the correct answer with rationale. And you have a nasty examiner like Arvind, he'll keep troubling you.
I think there's no what happens in the real world. A lot of some institutions and may actually practice frozen section for all their specimen derived frozen section for all their specimens. I think that is something that you can sort of see and defend. But then you must understand that institutional practice is one thing, and what is the evidence is another thing. So again, the larger point I wanted to make is that your gross adequate margins, you get it right the first time, and that's the best thing. And of course, this Mustafa Bulbul's meta-analysis, I think Tatas were also a part of it, I guess. If the R1 was converted to R0 also, it didn't really show much of a benefit in terms of outcomes for these patients. And I'm sure, I think Sir might allude to during the course of his talk, but I guess we'll just move on to the extent of neck dissection. And you all said levels 1 to 4.
Yes,
Right?
sir.
Pratik, you said, both of you
Yes,
all
sir.
said, in fact, 1 to 4.
Yes, sir.
But before that, Shiva's asked whether it is yes or no. Do you want to operate the neck?
yes,
Oh,
sir.
yeah.
Yes, sir.
Okay, I'm not going to be conceited and ask you why, but I'm going to ask you, when do you not operate the neck?
We operate for all the cases, sir.
All.
It's all elective neck dissection, sir, yes. Irrespective of the T stage and the depth of invasion. There is
Supposing there's a lesion that looks like erythroleukoplakia, I did a biopsy, it came as squamous. It's a musca lesion, as someone else says, it's only on the mucosa. You'll do the neck?
So there are studies that show that up to less, if the depth of invasion is less than 3 millimeter, then we can observe the neck and
Which studies said that?
Sir, I don't remember the paper.
3 millimeter cutoff was from which study?
Scent study. I'm not sure.
My two
I think Dr. De
youngsters-
Cruz is
1 minute.
not happy.
1 minute. My two youngsters, when you all go for exams, find out who your examiner is. And please read 1 or 2 papers they have done and then go for the exams. And even when you give a talk in conferences, always praise your host. They'll always say your talk is good. Quote one of their studies, even if it doesn't matter. Anyway, quickly, I'll tell you, our study showed 3 millimeters, but what does the meta-analysis show?
What does the SEND study, and subsequent there was some 8 or 10 meta-analysis.
So they show that there's a survival advantage even with a depth of patient
Lesser
than
also. So you're right, Richard, that that more or less, but in the context in which Sir had said, like, supposing somebody has done an excision for an erythroleukoplakia and then the sort of depth is a millimeter or so, then you may choose to sort of observe. So in those very, very highly select patients or something like that, but you're right, for the vast majority of them, you would do a form of elective neck dissection.
Anyway,
or you address the neck. Yeah.
Quickly, for all the people listening, the meta-analysis is by first author Sophie Yuang, Cancer, and it's from Brian Sullivan's Toronto group. They showed 4 millimeters as a cutoff. So anything less than 4 millimeters for years was considered as you don't operate the neck. Till our study came and we said 3 and you must operate the neck. But to quickly tell your examiners, you can tell them, sir, when it's very, very superficial, I will not operate the neck, mucosal disease, or if the patient is operated by a surgeon and it's a TX disease, margins clean, 2 millimeters, come to me for a second opinion, whether the neck should be done or not done, I will observe the neck. Because there's no data to show less than 3 millimeters, there is an advantage of doing the neck. So when they ask you when you will not do the neck, these are the 2 indications. Prateek, do you agree with me?
Yes, sir.
Okay, good. And Shiva, if you don't agree with anything Arvind or me are saying, please tell us.
Yeah, sure, sir. Yeah.
Okay.
The extent, yeah.
I had the same query. Both were, said 1 to 4, up front.
Yeah. I think it's...
What is the evidence behind that?
So level 4.
Again, let me ask you a question. What was the extent of the neck dissection in the N0 trial by Dr. De Cruz?
So for it was as levels 1 to 3 were removed, and level 4 for tongue cancer.
Dr. Richa?
So 1, 2, 3 were removed for all the patients, and if there were grossly positive nodes in many of these levels, then
it was 1 to 3. Yeah. So now answer now. So in Sir's trial, it was 1 to 3 because I was also a part of the operating team when they started off in the trial in 2004. It was 1 to 3. Now answer the question, the extent.
So minimum, I would like to do level 1, 2, 3, and if there are positive nodes in any of these levels, maybe level 4 also. Historically, the data was there is a skip metastasis to level 4 of about 16%, but the current studies do not prove that. So we can avoid level 4 if there are no positive nodes in level 1, 2, and 3.
Prateek?
Only it's the same. So only Bayer's paper from that's an old study. It showed around 16% metastasis in the level 4.
But there are a lot of flaws in the study. Actually, it didn't show 16 anyway. The numbers, if you see, actually it showed anywhere between maybe, I guess, 3% or so. If you actually see, it was a sort of jugglery of data that they sort of extrapolated to 15.8%.
So they didn't consider the previous. They didn't consider the 1 to 3 node positivity. They included all of the level 4.
They considered 6%.
No. Bayer's paper was 15.8%, but the flaws in the paper were they looked at level 4 nodes They didn't tell us whether the nodes were positive in 1, 2, and 3.
1, 2, and 3, yes.
And the second thing, they also looked at failures at level 4. And that's the reason why very often you operate and then you get a lymphatic met that comes low down in the neck. That doesn't mean if you had operated level 4, even if you do a full neck, you can get that met at the lower end of the clavicle, the medial end of the clavicle. So those were the flaws of bias paper. But we'll quickly skip. We don't do that. And I'll probably show a slide when I'm doing my talk at the end of this clinic.
Other thing is, what is the approximate percentage of positivity in levels 4 and 5 and 2B?
2 to 5.
Or levels 4, you tell, because you all were very sort of, both of you all very strong proponents of level 4. So that's why, in what percentage of a clinico-radiologically N0 neck would you have level 4 positivity, or level 5 for that matter?
Less than 2%, sir.
4% or so.
2 to 4%. Yes, sir.
Yeah. Okay, I think the next question is, Shiva has put up a sentinel node biopsy. I'm sure there are a lot of interesting caveats about the N0, which sir, I'm sure would sort of, tell you in his talks. That's why we'll proceed in the interest of time.
Right.
Sentinel node? Yes, no?
No, sir.
No, sir.
No?
No, sir.
Why?
No, but Richa, that's not a right answer, Pratik. No answer. The examiner will ask you why not. You can't say no.
It's a part of a guideline. If there is a resource, if there is a setting in which there is no dearth of sort of anything, all resources are there, would you not do?
If
So
it is
the-
available, then we can consider, say, it's there in the guidelines, so for early lesions, and so we can do, but so it will entail a second surgery because we need serial sectioning of the sentinel node to confirm. So the patient should
In
be
what percentage that would require a second surgery?
I think so I think 16 or 17%. I do not remember the exact value, sir. It's
Yeah, different in different studies. It was
different
16% in one, 30%. It ranges between 15 to 30% or so.
yes,
Right.
sir.
It depends on the time. But Pratik and Richa, you all should be little decisive in your answers. When he asked you, will you do sentinel node? You should say, sir, this is an evolving technique. It is shown to be safe, but there is no compelling superiority over an elective neck dissection as of now. So if facilities are available, I may consider, but in our institution, we still do the SOHD. Then he will ask you all, why is it not? Then you can, that's when you're going for the gold medal. But bury the answer with a decisive answer. Don't say no, and he'll say, I do it. And then unnecessarily you all will get into, into a web. Then they pull you down, and then you're subsequent, you make silly mistakes. Okay.
What are the technical challenges of doing a sentinel node biopsy? The evidence, I'm sure that we can discuss later. Maybe sir can. Challenges of doing a sentinel node biopsy, technical challenges.
It has a long learning curve, and
correct.
Then so the dye spillage can lead to a sign through effect in the floor of mouth lesions. So it can.
No, is it spillage? Is it spillage?
So the in floor of
It's
mouth lesion,
close to them.
It's close.
It's close.
That's right.
It's in proximity.
The
And
cost issues are also there, sir.
Cost issues are
Cost
there.
issues.
Then requirement of a second surgery.
Then a third of patients you may have. And the other thing is, you did mention that
morbidity is same, sir. When we compare the sentinel lymph node and a
long-term morbidity
12 months
and what do you do in the sentinel node? How many sections do you take? How many sections do the pathologist need to take? You said one of you all said serial subsection, right?
Yes, sir.
So how, at what
2 to 3 mm?
No, 1 mm.
It's in microns. It's in microns, my friend.
Okay, so all these things, so you have to at least know the evidence is one part, but then these are the other issues. And quickly, reconstruction. your
So in
choice
this-
of reconstruction in this
this
particular
case,
patient?
sir, primary closure will be possible, sir. There will be the loss of volume will be less than 30%. So the primary closure can be easily done, sir, in this case.
Right.
So when do you do again? What is the 30% rule like?
So there's a paper from Amrita that less than 30% after, if there's a tongue defect, the swallowing does not is not hampered if you do a primary closure. So you can.
So do we have to believe the Amrita paper? In Jalandhar, they say 35%. And in Delhi, they say 25%. And guys in private practice say even 10%. Who should I believe?
So again, there is a meta-analysis to sort of suggest less than 20, 20 to 40, and more than 40. Yeah. So in less than 20%, you can sort of do a primary closure, and more than 40, you do what is called as a flap-based reconstruction. You could be a local or a free flap. In 20 to 40, I guess there's no clear answers.
Gray zone.
Yeah. And quickly, the last point: oral feeding protocols. Anything that you want to say about this, Dr. Richa?
Sir, we can start oral feeding from the next day of surgery itself. Like starting with the clear liquids and then gradually stepping up. It's a primary closure case. We need not keep the patient nail by mouth for a long time. So for his swallowing to come back.
So in which wide excisions will you initiate feeding later? Every patient you will initiate on day 1, is it?
Sir, but clear water, yes, sir.
Day 1. No wide excision. Supposing you do a little modified excision, is there any case? When are you bothered that there may be a leak?
So when there is a lesion is extending up to the base of the tongue and we have done a total glossectomy, maybe then patient won't be able to swallow.
No. For early oral cancers, with the total glossectomies, if you feed on day 1, I'm coming to your institution to learn as a resident.
No, sir, not for the total glossectomy cases.
And you're saying total glossectomy with base tongue excision.
So for
in early oral cancer, see, you just open your chat box. All these leadership are giving all the answers there. Read, open the chat box and see what Rudra has written. If you go close to the floor of mouth, then you don't start early. So your answer should be, sir, when I'm not sure about my floor of mouth, whether there's a communication with the neck, I will hold on to oral feeds. Otherwise, I will start my feeds early. Right. Don't be dogmatic one. And how do you know you have come close to the floor of mouth? One is you can put your finger and you can see the digastric, or you can see the digastric from the head end. Any other method? If you excise and go below the sublingual gland, you're into the floor of mouth. You have communicated. So if you take the sublingual gland, then the chances of your suture line breaking down, it is not supported, then you will have a leak and you might start later.
Right.
And in those cases, how do you close? All this free flap and all, everybody knows. You still want to close primarily, what will you do?
We'll do a mucosal advancement of the gingival mucosa.
You might have to buttress your suture line with the floor of mouth muscles.
Yes, sir.
Okay. Sometimes you can use the platysma also to buttress it. Many options are there. So, are you aware of any classification of tongue dissections?
Yes, so there are type 1 to type 5 types of defect. Minali classification.
Pardon?
Minali classification.
Minali.
Oh, it starts with A.
Ansarine classification.
Ansarine classification.
Italian.
Yeah.
Yes,
so, what type of ansarine classification would this fit into?
So this will be a type 2
right.
classification.
Right. You are aware, no? I think that
Yes,
is something that, that is something that you all should be aware, because that is something that is more popular nowadays.
Yeah.
And it's endorsed by multiple societies as well.
Right. So I think in the interest of time, shall we move ahead to the second?
Yeah, sure. We can.
Just
Sure.
try to a bit of the advanced disease as well.
Sure.
Oh, sorry. There's still the
And I think we'll go to the next case, Shiva.
yeah.
No, make one comment here. Boys, girls, what is the comment here? Is this a good report? Look at the second last point. How many nodes should you have?
So guidelines recommend a minimum of 18 nodes to be removed.
Okay, always look at that.
Yes, sir.
Which
And
guideline says 18 nodes?
Existing-
Multiple studies say. I think it's a part of a particular
NCCN
guideline as
guidelines.
well.
Yes, sir.
Pardon?
So in the NCCN
Sir was
guidelines, it is-
pardon?
Sorry, sir.
Sir was also a part of the guideline.
Yes,
So it's a ASCO guideline. So again, multiple studies. It's not just the guideline, but multiple studies also say even very recently, a Latin American guideline also came a couple of days back. So they also seem to endorse the magic number of 18.
Okay. So if just one of the examiners can just give their opinion as to whether this patient can be, kept under observation, or would they do anything else beyond the observation, and then we can move on to the next case, just for the sake of completion for this case.
I would observe.
Observe.
So this is observed.
Yeah, I would agree with that, because this was put because just presence of PNI alone is not an indication to add adjuvant therapy, and evidence for this at this point in time is not robust, and still there's
we are awaiting evidence.
the results. Accrual of the patients in that arrest trial is done.
Arrest
and-
trial.
Yeah, the
But
results.
Shiva, since you are on PNI and these are all young students, many of them will go for gold medals. In PNI, which types of PNI are dangerous? He's put two words in the bracket and we said we'll observe. Now change those two words and tell us which PNI is dangerous.
Extratumoral PNIs with
Very
the-
good. Very
Right.
good. And then what is this focal?
So focal is at only one part. So if it is diffuse, then we'll have to.
So some nasty examiner might, like me, will ask you who was Lippic. Do you know any classification? Okay, someone has said, please go through the other two cases. Please read it. Chalo, skip.
Right. So just quickly going across case 2. This is a 42-year-old gentleman who came with complaint of growth in the oral cavity of 3 months duration associated with occasional bleeding and pain. And he had history of use of tobacco, smokeless tobacco for over 20 years, reformed with no comorbidities. That is the clinical image. On examination, he had one finger breadth mouth opening, had an ultra-proliferative growth in the buccal mucosa, approximately 5 to 3 centimeters. The clinical examination, however, showed the upper alveolus appeared to be free. Skin was involved, as can be seen. There were no loose tooth. On palpation of the neck, there was 1.5 centimeters palpable 1B node. And I think the workup we have already discussed, the biopsy imaging, anything in particular for imaging at this point, examiners would like to add. I think most of it has been discussed already.
Yeah.
So this is the CT picture, a CCT coronal and axial picture of the same patient. The examiners can ask the questions from this, if there's any.
Would you like to do a PET CT as a one-stop shot for this patient? Dr. Richa and Dr. Pratik, anybody?
It's only a 1B node is positive, so we can do a CT thorax.
It's a T4A.
T4A and one.
Yeah.
Yes, sir.
Skin involvement.
Skin involvement is there.
I think, Shiva, the question, just put your cursor on that air shadow on the opposite side.
Yeah.
Put your cursor there, Shiva, on the opposite side air shadow.
One here.
On the right hand, on the right image on the screen.
Yeah, this one you're saying.
Yeah,
okay.
yeah. What has he put his cursor on?
This is a puff cheek CT scan. The patient has puffed his cheeks. That's
Yeah.
why.
So why do you do that? That's the question they'll ask you.
So we can see the small lesions in the buccal mucosa, and the GB sulcus will be more clearly delineated, so we will not miss any.
It's basically GB sulcus, but remember one thing, this is a radiological assessment. For us, we look at it clinically.
Yes, sir.
The radiologist wants to tell us whether the bone is close, whether it's lifting, but generally we use our clinical judgment to decide whether you're doing a marginal paramandibular spread. This ain't too good for us.
Right.
Okay.
Right.
So
that is the clinical radiologically, the clinical stage is T4A N1 and M0. Coming on.
Why T4A, Dr. Richa?
So because the skin is involved, sir.
Correct, skin is involved. What about the mandible? Any comments?
So there is no bony erosion in this view, sir. However, I would like to see a bony window to confirm my models.
So any other comment you would want to make, say, assuming the bony window is normal, based on these two images? I'm saying the bony window does not show bony involvement.
But the paramandibular spread is very...
Right. Clinically also you can make out, and radiology also you are able to make out paramandibular. And Shiva is saying T4A N1.
Right.
Okay, assuming that you've done a CT chest.
Yes, sir.
Yeah, and no metastasis. Management.
Go for surgery first.
Okay.
So it will involve a wide excision of the a lesion with the overlying skin and a segmental mandibulectomy along with the paramandibular tissue, soft tissue with adequate margins, sir. And a supraomohyoid neck dissection, sir.
So comprehensive neck dissection, sir.
Comprehensive neck dissection. Okay. What about any role of NACT, Dr. Richa?
Sir, if it's upfront operable, we should go ahead with surgery, sir.
Okay.
How do you know it's operable or not operable? What will decide that in this case? Don't give me base skull involvement and other things. In this case, how will you know whether it's operable or you should give chemo?
So if the edema was reaching up to the zygoma or the disease was reaching below up to the hyoid bone, it will be borderline resectable. And in those cases, we can consider for giving neoadjuvant chemotherapy. Sir.
Okay. I would answer it differently, and I'll show you one slide when I speak. If as a surgeon, I'm sure I will get negative margins, I would operate this patient. If the edema is not reaching the zygoma, but I have to remove all his face below the zygoma, I won't operate this patient. Does that make sense?
Yes.
Yeah, it has to. So, anything you would, of course, theoretically, you can conserve any structure here. The second question, any role of NACT other than borderline operable?
Sir, we can give it for mandibular preservation, but this patient
was
gross paramandibular.
Okay, so that's a thought. So just keep it in mind. Maybe we can deliberate on that later. Extent of neck dissection, I think you wanted comprehensive neck dissection, Dr. Richa, and Dr. Pratik, you said SND, right?
So if it's only 1B, we can do an SND. Otherwise, a comprehensive neck dissection if lower levels are positive.
Right. Dr. Richa, why did you want SND? Comprehensive neck dissection?
Sir, it's already advanced lesion. It's a stage 4A already, T4A. So
your extent of neck dissection is based on the T status?
No, so depth of...
or on the N status? So the other question, earlier, I think the teaching was that you do a comprehensive neck dissection for any node positive.
Yes, sir.
But I think the concepts are changing, and of course, not recently, maybe since past 10 or 15 years, it's been changing. But you may want to do What are the indications to do a selective neck dissection in an N plus neck?
So it is
if it's
single
a-
mobile.
Or when do you not do? You can answer it that way also. What are the contraindications for a selective neck dissection in an N plus neck?
So non-fixed nodes should not be fixed. Like if the nodes are
Right.
fixed or there are multiple nodes at multiple levels, and clinically
Bulky
palpable
N2,
nodes
N3,
clinically palpable nodes,
in level 4
multiple
and 5.
levels.
lower level nodes.
Yeah. Again, multiple nodes, large N2 or N3 nodes.
And N2 or N3
And
nodes.
with this model, you may not want to set it.
Yes, sir.
Maybe we can.
So the question actually was when will they do a tracheostomy in
Right.
surgeries and subsequently decannulation protocol. So the question was not.
No, that's fine. I think we can go to that because considering the defect possibly in all probability surgeries, then we would have done a free flap. So let's go to the when can you avoid a tracheostomy in oral cancers?
So if the lesion is anterior and the defects are anterior and the
anterior.
So if the defect is not crossing the midline, we can
this
probably not do a tracheostomy. If the like our resection has gone beyond the midline or the reconstruction is too bulky, we should do a tracheostomy.
Right.
And what is the protocol? Like, what do you normally do for tracheostomy decannulation?
So like first we initially we changed to the uncuffed tube maybe on post-op day 1st or 2nd, and by 3rd or 4th day we try decannulating the patient.
So there are two protocols for tracheostomy decannulation. Anything, Dr. Pratik?
So I am not aware of protocols.
So do you like one is Dr. Richard said that you would sort of change to a lower cuff tube or a non-cuff tube. Do you believe in corking? Have you
yes, sir. Corking we have done.
No, I'm just asking, what is your clinical practice in places where you're working? Would you do corking, or how do you decide that this patient is fit for decannulation?
So we see the swallowing of the patient and we check the supraglottic aspirate. If it is, if we usually use a cuff tube for tracheostomy, we check the supraglottic aspirate, and if it is not much and the patient is able to, the palatal movements and the tongue movements has returned back. So we do a corking of the patient after deflating the tube, and then we gradually decannulate the patient if it tolerates.
Do you all? Yeah, sir, you can.
I just wanted to jump in. When you asked them about tracheostomy, you all were very vague in your answers. Again, please be decisive. There are many indications why you do a tracheostomy. It's not only anterior is fine. If you go across the midline is fine. When you do the middle third mandible, it's fine. When you feel that the tongue will fall back or you do a major glossectomy, it's fine. When you have aspiration problems, even sometimes with a bulky flap, with a very obese man, you'll do a tracheostomy. You'll do a tracheostomy when the patient is COPD and has minor risk of aspiration. So please answer like a DNB MCH candidate. Sir, say there are multiple factors, anatomical factors, risk of aspiration, patient factors, then I will decide that I want to do the tracheostomy. When will you remove the tracheostomy? Supraglottic aspirate when the patient is okay and is not aspirating and I've instituted oral feeds.
Right.
That's how you should answer. Don't give these one-line answers to your examiner. They should know what you're doing in the ward is okay and you have spent time in the ward.
Right.
Okay, look at the report.
Yeah, answer the question. I think quickly have a look at the report and decide on the adjuvant treatment.
Yeah, so the skin and bone both are involved, and patient has multiple PNI. 4 nodes are positive, but none of them have extranodal extension. So it's a T4A N2B. So question regarding adjuvant.
Since it's a T4A lesion and already nodes positive, so for patient will require adjuvant RT. He already has PNI is positive and it's multifocal intertumor.
I would give chemo RT. Am I wrong, Dr. Richa?
Sir, the definite indication of giving chemo RT will be a positive margin, or if there is an extranodal.
No, but in this case, you're right. You're right. What you're telling is right. We all know that since 2004, after the seminal trials in RTOG and EORTC. Dr. Pratik, I would give chemotherapy and radiation for this patient.
So I'd like to discuss this in my MDT tumor board and then decide.
That is in real life, but in exams.
So there are indications we can give because the depth is more than 10 millimeter. The PNI is positive, and but there is no LVI. Only 2 additional minor factors are there.
No, again, I think there are no, there's no very, very strong evidence, but there are some retrospective data right from 2017 onwards to some NCDB databases, which suggests that, can you give for multiple nodes? More than 4 nodes with
Yes, sir.
PNI.
So these are minor factors, multiple nodes, PNI positivity, LVI positivity, and a depth more than 10 millimeters. Yeah.
Right.
Yeah, it's a contentious issue, but I think I would give, sir, Dr. De Cruz, what do you, sir?
I'll probably show them one slide when I speak, but you all have finished whatever I had slides on. I'm just wondering whether we should.
There's one more case, no?
Just last case, and then I think we can move on to search. So I'll quickly run through this slide. 30-year-old gentleman complains of growth in the oral cavity for 3 months associated with pain, tobacco user, no comorbidities. On examination, there's a decreased mouth opening, almost nil, ultra-proliferative growth of approximately 6 into 4 centimeters. The skin is not pinchable and palpable 1B and level 2 nodes. That is the CT image. Over to you, sir.
Comment, youngsters, look at the CT image and comment. What level is it on?
So it's a supranotch disease. And
how do you know supranotch?
So here in the CT scan on the left side, so we can see it is already.
What you can see?
So the disease had reached the above the notch, sir, the sigmoid notch.
No, which is the structure that tells you it's the notch? You're correct, but which is the structure? How do you know?
This we can see only the condyle and the cornoids are separate.
Yeah, absolutely. That's the point. And you can see the nasopharynx here.
You can see the.
Okay, good. Excellent. So what will you do? Posterior wall of the maxilla is eroded. It's going up to the pterygoid plates.
Right.
Posterior.
So what will we do for this patient? T4, BN2, surgery, NACT followed by reassessment. What will you do? Operate? Give just chemo radiotherapy?
So in this case, so this falls in the criteria of, sir, it's in the criteria of inoperable due to the pterygoid plates involvement. So I would like to.
Would it be inoperable or borderline operable?
So different studies say different. As per it would be borderline operable, sir, but the pterygoid plates are already involved, sir. That's why.
The lateral pterygoid and all will all be involved.
Yes, sir.
So what would make it inoperable? In this aspect, don't tell me about, say, encasement of carotid and things.
So the foramen ovale involvement of the pterygomaxillary fissure and the foramen ovale we have to see.
It's there then. So what would you give, treatment, broad treatment philosophy.
Shiva's already told that he's giving neo because his next question tells you 2 drugs or 3 drugs. He's giving you all clues. He's the internal examiner. 2 drugs, 3 drugs.
So 3 drugs has a better response, but less tolerability when compared to 2 drugs.
Name the drugs, name the dose. They should have warned you that I'm a nasty guy, Richa. No one told you? Pratik.
Sir, TPF, taxane based, it could be paclitaxel or and sir, carboplatin or cisplatin, depending on the toxicity, and 5-fluorouracil. So the doses is so it's 75 milligram per meter square for paclitaxel and cisplatin.
The dose, you tell docetaxel, cisplatin, 5-fluorouracil.
Docetaxel, yes, sir.
Okay, so that's the classical thing. You can, as you rightly said, you can tweak it, but the classical is
it's a
very easy mnemonic. How 75, 75, 750 is it?
Yes, sir.
Huh? Right.
So
And,
DCF regime.
Yeah.
Okay. Shiva's called it off. He said thank you. And even he is asking us to do the talk, Chairperson Subbu.
Thank you.
Thank you.
Shiva, if you can get off, then I'll share my screen.
Yeah, I've stopped sharing, sir.
Okay. Help me to get this. Share screen. Then IASO, this one, no?
Moderator and the examiners, it was just wonderful. Very befitting as a inaugural session. We expected moderator to ask a few questions actually.
Exactly.
He was a pure moderator.
To the point, and very nice and very interactive.
And the examiners and the moderator, please stay back.
Yeah.
Stay back to listen to the legend.
No. Why not the students? Let the students also stay back.
We all are waiting for this.
Okay, great. So thanks, Subbu and leadership once again for giving me this opportunity. I feel elated that I lit the lamp today virtually, something I've done rarely. But I think you all both were great. Like I said, please be decisive in your answers. You all know the subject, but talk confidently. And as I tell my youngsters, even if you bullshit, if you're confident, the examiner sometimes accepts the answer. So I'm going to quickly cover, they told me to speak on updates. I thought of something fancy, and then our president wrote to me, Dr. Dev, and said, cover both aspects, keep it purely surgical. I'm going to give you all certain points, which you all should read, because examiners will ask you all if you all are doing well about these points. They may also come as short notes for you in your exam. And I'm not going to waste my time talking about the basics, which I think Shiva has put up great slides, and we have covered most of them in theory. So it's our cancer. Half the cases in the world are in our part of the world. And this is something that you all must know. Sometimes they ask you the incidence of this cancer, and you must know it's about 10 per 100,000, and mainly in Southeast Asia. About 400,000 new cases and 175,000 deaths globally because of oral cancer. It's the 16th most common cancer. And the reason why I put this up is you can see that the mortality is more or less similar to the incidence, as opposed to breast, which is the #1 cancer, but the mortality is much lower than lung cancer globally. So a large number of our oral cavity cancers, our patients succumb to disease. And why does this happen? Because of late presentation. The world over, oral cancer is aggressive and patients present very, very late. And how do we prevent this? And this could be a short note for y'all: screening of oral cancer. The reason it's a short note, it's our cancer and the only randomized controlled trial with mortality as an endpoint comes from the southern state of Kerala, and it's known as the Shankar Narayan trial, published in Lancet 2005. 100,000 patients approximately in both arms. One got health education, visual examination. One just got health education. 3 rounds of screening at 3 yearly intervals. There was no difference in survival in the 2 arms. But when they looked at high risk individuals who did consume alcohol and tobacco, there was a lowering in mortality. Screening of oral cancer, please prepare this paper. And we've moved to what is known as risk-based screening. We wrote a little editorial on this for the oral cancer. And the reason we wrote an editorial, because when they looked at Shankar Narayan's study, a rehash of the data in JCO, they showed that if you screened people who consumed tobacco and alcohol in high proportions, you would have a higher incidence of getting positive or success of your treatment. So for every 2,000 patients who were screened, you would prevent 1 death if you looked at the entire population. For every 1,200, it would be 1 death prevented if you looked at high risk individuals. And 610 individuals would need to be screened to prevent 1 death in 50% of individuals at the highest risk using the most tobacco and alcohol. So short note screening, Shankar Narayan study, and you talk about risk-based screening. Second short note or exam question. Pre-malignant conditions. Please note that these are not called pre-malignant anymore. It's called potentially malignant. And you must have these 5 bullets in your answer. Leukoplakia, erythroplakia, oral submucous fibrosis, hereditary disorders such as Fanconi's dyskeratosis congenita, immunosuppressed patients, hepatitis transplant have a higher incidence of having oral cancers, and lichen planus and HPV. And we have talked about these in the clinic. I'm not wasting time on these. 2 other things you have to write in your potentially malignant or pre-malignant lesion short note. There is no role for giving any antioxidants to your patients. Cochrane meta-analysis, 14 RCTs, close to 1,000 patients, looking at various vitamin A, beta carotene, herbal extracts. None of them showed to have a benefit. And exactly the same for early diagnosis. It is again a Cochrane meta-analysis 2-3 years back, looking at close to 8,000 patients in 63 studies. At present, none of the adjunctives, whether it is vital staining, whether it is oral cytology, whether it's light-based detection or oral spectroscopy, has any benefit. So I'm just giving you all clues. I'm giving you the reference. Please read it. I can't cover everything in detail. And the last thing that you all should read about is salivary biomarkers. Again, a short note. It's also known as saliva omics. They look at an array of potential biomarkers, either by oral rinse to look whether you can do home screening. They look at salivary genomics, epigenomics, proteomics, transcriptome, metabolomics, and microbiome. And I think that came up in our discussion as well. But again, at present, it's something that is evolving. It's not standard of care. It's been around for long, but recently, with all this NGS and other things coming up, again, this is having a revisit. So please prepare this also as a short note. Third important point, DOI, part of our staging now. We covered what is thickness, what is DOI, The line that goes across the mucosa is called the plumb line. Again, please read it. But when you write DOI, you can put the staging, you can draw a diagram to show what's the difference between thickness and DOI. But what is important is, while the ICOR study showed DOI is important, the same group published a paper looking at whether DOI is an important prognostic factor for post-operative radiotherapy in oral squamous cell cancers. 1,409 patients divided into 3 groups, less than 5, 5 to 10, more than 10 millimeters. If you look, those that had a higher DOI had higher bad risk features. Primary tumor size was large, N category was large, ECS was large, close or positive margins were large, and I've circled them here from the original publication. Now look what happens. If you have high DOI with at least one other adverse factor, you do have a benefit of giving radiotherapy. But if you have more than 1 centimeter with nothing adverse, look at the top graph, no difference in adding radiotherapy. So in your short note, write that it's part of the staging, but it may not be an individual. And please quote this ICOR Ibrahimi's study. And we have done exactly the same looking at DOI from our N0 randomized data published in IASO, and we show that for thin tumors less than 10 millimeters, if you did an elective neck dissection, it negates the prognostic impact of depth. If it's more than 10 millimeters, you have other adverse factors that influence the outcome. So these 2 studies, there are 3-4 other studies, but again, in the interest of time, I've not put it up. But you must cover in DOI this thought process to complete your entire short note. 4th, oral cancer is a surgical disease. For early stage disease, control rates are the same. As you go to advanced stage disease, surgery scores as the prime modality of treatment. So when they ask you, like Shiva put up a question for locally advanced, why not radiotherapy? Your answer should be a decisive. For early stage disease, control rates are the same. But for locally advanced disease, we prefer surgery because there is a survival and control advantage if that is first. And here is the study that Professor Krishnamurthy wanted you all to study, or quote, 6,900 NCDB databases, 2004 to 2012, published in the White Journal, JAMA Auto, head and neck, 4,800 at surgery, followed by post-op RT, 2,000 had CTRT, and you can just read the bottom bullet. Compared with CTRT, surgery plus post-op RT was stronger. So when they ask you, why is it better? Quote this NCDB database. There is another study from the Singapore group. Gopal Iyer is the first, but that looks at all subsites within the head and neck. An analysis in that study of the subset of oral cancer again showed the findings as in this large NCDB databases. The question they ask you often in the clinic or in your case, what constitutes an ideal margin? Number of studies showing that from 1 millimeter all the way up to 7 millimeters is important. But the answer, Richa, what I told you is, quote Carolyn Anderson, looking at 5 studies that looked at local risk recurrence following excision without adjuvant therapy. If you had less than 5 millimeters, the recurrent rates were pooled to give a 21% absolute risk reduction. Look at the p-value, 0.00001. if you went 5 millimeters or more. Very compelling evidence that you should do 5 millimeters. So again, when you'll answer in the exam, don't say 1, don't say 2, don't say 8, don't say 7. Say that minimum of 5 and quote this study. You always operate. The choice of flap is a free flap. You have much better results. Here I'm showing you a case with locally advanced cancer. We have used a double free flap to reconstruct the mandible and the skin, and you can see a fairly decent post-operative. So even if you need to have a double free flap, you will operate. Here we've done a case where we've removed more than half the face, 4 struts of the fibula, reconstructed the face, and you all will agree that cosmesis and functions look pretty good. So when do you call it a day and you don't want to operate? The question that Professor Krishnamurthy asked you. The surgeon must be reasonably certain of a negative margin. You should have good reconstruction to give a good quality of life, and you operate patients who are biologically favorable. No dermal nodules, no large nodes, and should have a good GC to tolerate adjuvant treatment. So when your examiner asks you, when do you operate? Remember these 3 bullets and answer them accordingly. So that there's not that carotid involvement, base skull involvement, that everybody knows. But this is when, and even use it in your practice once you'll get your degrees and you'll operate in practice. Surgery is only avoided early case lesions in 2 indications. One, when you have a lip lesion as seen here, which is superficial, or the commissure is involved. Here is a case in point of one of my patients treated with brachytherapy. Here is the result 6 months later. However good a surgeon you are, you'll never be able to reconstruct this lip. And the other indication you do it is in the palate, where you don't have bone erosion. Again, in the interest of time, I've not put those photographs up, and I don't have permission of the patient to show them. And it's called contact brachytherapy. So please remember, sometime when you have a nasty examiner, 2 questions are asked. What is the type of brachytherapy? There are 2 types that we use. One is interstitial brachytherapy, where you put wires, and the second is contact brachytherapy, where you put surface molds onto the palate to treat an early lesion that is not eroding bone. If you operate it, you'll fenestrate the palate because the mucoperiosteum is stuck to the bone, and you have to take out the bone, otherwise you won't get a deep margin. So there we'll always give contact radiotherapy. The masticator space, again, this case was put up. What's the difference between masticator and infratemporal? Clearly shown here, the yellow is the infratemporal that we are concerned about as surgeons. The radiologist reports the masticator space shown in green. So please again read the difference between the 2. For us, it is the masseter is not a contraindication for surgery, while the infratemporal fossa is a contraindication for surgery. And here is the paper that decided on the supranotch or infranotch for beak tumors, Liao et al. Please remember, this only had 47 cases, and they showed a statistically significant difference between infranotch and supranotch. But if you had to quote more, this came from Taiwan. Here is real world data from Taiwan, published a year and a half ago, looking at T4A and T4B results from the Taiwanese registry-based nationwide cohort study. 6 years data, 4,000 patients with T4A, 355 with T4B, If you look at the second last bullet, again, I'm going through this quickly. Note the reference, read it yourself. After propensity scoring match cohort, there was no outcome differences between T4B and T4A. So basically, if you get negative margins in T4B, you will operate your patients. You will not otherwise operate them. And the cutoff is the notch or the lateral pterygoid muscle. If the lateral pterygoid is involved, you will not be able to get a superior margin. And this paper has very elegantly tabulated all the published studies, including some from our country. And I'm just putting my cursor there to show the ones from our country. And again, showing that T4B cancers have bad prognostic factors, as in the Taiwanese nationwide study, more extranodal, more positive margins. But if you choose your patients correctly, you will get fairly decent control rates. So if the examiner asks you, please quote the Liao paper, please quote this paper nationwide, and mug up one or two Indian papers, Vijay Pillai's and the others, and you can quote those papers as well. We also have compartmental resection for tongue. And this is based on the sarcoma concept, that we believe that the tongue has two embryologically distinct halves. And if you operate the tongue and you do a compartmental excision, you get better control rates. Popularized by Calabrese from Italy, 2009. Remember this name. What are the three components? Anatomical approach to remove the primary lesion and all potential pathways of progression, muscle, lymph, and vascular. Second, identification of a distinct territory at risk for metastatic representation of disease. Basically, the extrinsic muscle and the sublingual or submandibular spaces. And third, you prepare your patient for a rational reconstruction considering the functional defect. This is the basis of compartmental resection. However, the same group has done a study looking, 4 institutions have pooled in data, and one is our Amrita group. Here you can see Subbu Iyer's name, you can see KK's name, Narayan's name is there, and 3 institutions from Italy looking at close to 1,000 patients, 641 wide excisions, 110 compartmental excisions. Again, when they did what is known as propensity scoring, they found that there was no benefit in this compartmental. So you can do compartmental, but again in the exam, please answer that there is no conclusive evidence that it has a benefit. For the seniors listening, for others, for the exam, and for your practice, I do compartmental excision in 5 indications. 1, when there's sublingual space involvement. 2, when there's extrinsic muscle involvement, you can see it here. 3, when the neurovascular bundles are involved, you can see it here beautifully. 4, when you have floor of mouth involvement. And 5, for large T2, T3 lesions on one side of the midline. If it's, or just crossing the midline, I always do a compartmental. But again, there is no conclusive proof that doing a compartmental for other lesions is of benefit. Short note, compartmental excision, cover both buccal and tongue. Compartmental extension of tongue, please quote Calabrese, and you can quote me unpublished but personal experience with the 5 indications. Adjuvant radio chemo. So we know the indications, all T3, T4, all close or positive margins. The ones that I marked with red are the ones that are debatable. Close margins, high grade, single node positive. Depth of invasion, today we take 1 centimeter. Anything more, guidelines say that you have to give it, though I told you all the ICOR study. But for the exam, say it's more than 1 centimeter, it's T3, I will give radiotherapy. However, sir, there is a study by Ibrahimi that shows this, what I've already shared with you. We know that chemoradiotherapy is for the ones that are marked with 1 extranodal spread or perinodal extension and positive margins. But time is changing and there is data, and please remember this. This is the Trifoletti paper. They are looking beyond positive margins and extracapsular extension. NCDB database 2004 to 2012. They're looking at a subset of patients with negative margins and no ECE, 10,000 patients, about 5,000 oral cancer, and they do show a survival benefit when you have multiple nodes positive. And I think Shiva was leading you all on that there are 4 nodes positive. Would you give CTRT? There's no conclusive prospective evidence, but there is data that is emerging that multiple nodes you can add CT. Please discuss with your patient and in your tumor board, and you may advocate. So of patients with multiple nodes, high risk of recurrence, I always discuss, and about 50 to 60% with good GC would get chemoradiotherapy. How many nodes? Here is a study that you must quote, and this is from Zacharias Zumsteg, looking at again NCDB database. Cutoff of nodes, there was no benefit with 0 to 2 nodes. Please look at my last bullet. Benefit was seen in those between 3 to 5 nodes, and those more than 6 nodes, it became still more significant. So generally the cutoff that we use is 4 or more nodes. We give our patients chemoradiotherapy. So expanded indications for CTRT, Trefoletti's paper and Zachary Zumsteg's paper is what you all will quote in the exam when Shiva asks you, would you give your patients with 4 nodes positive chemoradiotherapy? I'm quickly going to neck. Wherever I speak, I always have to speak on neck because most of my research came, but very, very quickly, and I'll put it all in perspective. So the therapeutic versus the elective neck dissection for the clinico-radiological node negative has been resolved with our paper. Any JM, you save lives if you do the neck. Overall difference in survival, 12.5%. Overall difference in disease-free survival, 23.6%. So 1 death for every 8 patients, powered on 12.5%. 1 recurrence for every 4 patients, powered on 23.6, which is close to 25%. So please remember this paper, level 1 evidence to show that you must do the neck. Second randomized study that stopped when our results were published, it's called the SEND trial. They at that time had randomized 250 patients. They added 346 observational studies and showed exactly the same benefit. And they also showed it for T1 tumors, 19.1% occult disease found in T1 papers. First author, Ian Hutchison. 8 subsequent randomized meta-analysis focus on the right-hand column, all of them showing that you must do a neck. There is some benefit in doing the neck in the clinico-radiological. So answer the examiner, we've got an Indian trial, we've got a British trial, and we've got 8 meta-analysis, sir. And I would always do depth of invasion. We discussed 3 millimeters and less, and I'm not going to repeat that because we've already done it in the clinic. Now, Arvind was troubling you all about 2B, 4, 5. So here is the data that you all have to quote. 2B, meta-analysis, systematic review. 455 abstracts, 129 full text papers, 22 studies selected. 2,000 patients. 112 had 2B nodes with a pooled frequency of 6%. 400 patients with tongue cancer, 12 studies, pooled incidence 7. So in tongue, higher incidence of level 2B. And 2B was always together with 2A. Only 3 patients had 2B in isolation without 2A. So please quote this meta-analysis and say, sir, there is no gross 2A nodes. I'm quoting the systematic review and meta-analysis. The incidence of having 2B in the absence of 2A is very low. Another thing that Arvind was troubling you all about level 4 nodes. Again, I'm putting up data. Just take a photograph and read these and quote it in your exam. Looking at skip metastasis at level 4. Level 4 involvement 0 to 11% with a fixed effects model of 2.53. True skip metastasis to level 4, and I told you what were the fallacies of the Bayer's paper. You can see how low it is. So supraomohyoid neck dissection is adequate for the CN0 neck. In tongue, you may have skip metastasis up to 3.6%. Association of T stage with skip metastasis not well analyzed in this meta-analysis. So the answer you give your examiner, sir, SOHD is adequate. I'm quoting this meta-analysis in the white journal. However, because tongue has an incidence of 3.6%, I will go ahead, retract the omohyoid and take out the fibrofatty tissue below the omohyoid, but I won't go all the way up to the clavicle and have risk of chyle leak or damage to the major vessels at the root of the neck, because my meta-analysis tells me that the incidence of isolated 4 is low. But to answer Richa's question, if there were other nodes available, then you would do the neck dissection. And we discussed this minimum of 18 nodes, and this comes from the IASO guidelines. What should you do for the N positive neck? And this again, Arvind tried to trouble you all when he was asking questions. So here is a meta-analysis of 5 studies, 443 patients looking at selective versus comprehensive neck dissection. Not a very new paper, Liang's paper 2015. They looked at ipsilateral, contralateral, and overall neck recurrence for a supraomohyoid selective versus comprehensive. Look at disease-specific death rates, look at overall death rates, p-value not significant. So there are some cases in which you can do a selective neck dissection even with node positive. And what are these cases? Again, a systematic review from the Alfio-Ferlito's group, PRISMA guidelines, systematic review and meta-analysis published in Head and Neck. From reviewed literature, SND is a valid option in patients with CN1 and select CN2 neck disease, which are non-fixed, absence of palpable metastasis at level 4 and 5, or they are not large volume more than 3 centimeters, or multiple lymph nodes at multiple levels. So if you have a small volume which is in the upper neck. Even if it is positive, you can do a selective neck dissection. Please quote the Farlito systematic review and review of literature, and please quote the Liang meta-analysis, Oral Oncology 2015. They asked you about sentinel node biopsy. 2 randomized control trials. Again, in the incidence of time, I'm not saying, you all must know this. One is the French trial, Garel, and one is the Hasegawa trial, Japanese, both published in the Journal of Clinical Oncology. Subsequently, 3 meta-analyses. Please know this. One from Tejpal Gupta from ACTREC, which is a part of Tata Hospital, Ding and Corsetta. All 3 meta-analyses show that both are equal, but the morbidity is less if you do the SNB, but it neutralizes within 1 year. And I've put these references down for you all to read this data. So there is a role for sentinel node biopsy, but you all said we will not do. This is the answer you should give the examiner. Sir, there is equivalence between sentinel node and the elective neck, but the learning curve is steep. It costs much more. It's cumbersome because it's a 2-stage procedure of nuclear, dye, plus I have to do serial step sectioning and IHC. Minimal. There is lovely paper showing that up to 6 sections can pick up IHC positive lymph nodes, and it can even go up to 10. So you have to do IHC. In those that are positive, you'll have to do a 2-step procedure, can be as high as a third. Though there are now techniques of rapid frozen, it's come down to 10 point some %, but you should say up to a third. And the morbidity is not like in breast and melanoma where the limb and usually shoulder function in a good done neck will come back to normal within 12 months. So if you don't do the sentinel node, and I'm concluding that oral cancer is preventable, amenable to early detection, is predominantly a surgical disease with good treatment options. I'd be happy to take, I finished on the dot of 9, but I put my email up for any of y'all who want to pick my brains on any questions or anything that I've said and y'all don't agree with. Thank you once again, Subbu and the leadership, for giving me this opportunity. It's great to be here with y'all guys, and it's wonderful, and congratulations to the leadership, and also congratulations to the 2 examinees. You all did very, very well. I would say I knew 1/10 of what you all guys knew when I was your age. Thank you.
Big people are always very humble. What an inspiration and an influence you are, Anil. Really.
But a pleasure. Thank you.
Yeah. And can we have the opinion of the other 2 examiners, the moderator and the other examiner, about the students? We missed that. We forgot that.
Arvind and
Yeah, I think they did well. They really did well, of course. And I must say that we took the level of the exam to a slightly higher level because they were answering well. And I think it really shows why they are the best. They've sort of gone and presented their work at SSO, and they've come back. And I really wish them well. Of course, as I said, we ask certain questions to tickle your palate so that you can read more and sort of crack for the gold medal in a way like that. So I really enjoyed the interactions with you all. And as usual,
IASO selects both the faculty and the students well, Arvind.
Right. Agree, sir.
I do agree.
Shiva, Shiva, you could have actually interacted. Moderator also is an examiner.
Right.
Anyway, next time.
And when DeCruz was there, I knew I had very little to do except for putting up the cases. So I just We enjoyed.
Shiva, say nice things. Everybody is listening to you.
Yes, that's exactly what I did, and I enjoyed doing the moderation, and I mean the two examinees were really good. I really congratulate them for having taken all the questions and answered. The only advice that I have for them is like what Dick Russo said. They have to be more decisive and try to be able to quote the common literature that is available, if not all. Thank you all.
Thank you very much. What else, Dr. Soprani, you want to say something? You are the oral surgeon who is a active office bearer for the past 2 decades.
It is really befitting that Dr. Anil and Arvind were the opening batsmen in this 2024 series of Masterclass, and both the examinees did well. And as Anil has, you are absolutely fantastic in your talk, and you are so thorough, and you have quoted the articles and the literature that these youngsters should know. And I keep on telling our trainees to do that only. And you must quote and be decisive in your examination.
Yes, now it's the turn of our secretary, the hardworking secretary, to give a vote of
I
thanks.
think
Formal
to have the first master class, it was one of the best master classes. And because we had previously done the oral cancer one, so there was a challenge that how we will avoid repetition, because all the master classes are recorded in the YouTube. So I think it was unanimous decision to give the moderator the previous one link, so that it is little modified and it is different, and there is no repetition. And I think with literature review and everything, with Professor De Cruz and Arvind, I think it definitely took to next level. And everybody, I think both the students also did very well, and they have worked hard on preparation. And especially, I thank Subbu sir and Srijan and the team for preparing the whole thing and making it always flawless from the beginning to end, starting from communication with the moderators to the chief guest to with the office bearers, regularly communicating in the ISO group to have the audience. I think at the top of our middle of our presentations, we were around 170 plus, and till now there are 100 people. So I think with this we popularize, but still then I believe that we can have with so many students, I think we can have more students to come into the classes and take the full advantage of the deliberations. And because how does it different from a postgraduate simple MS surgery is that only to quote the literature, you should be at every point of time, whether it is indication of PET scan or whether it indication of nodal dissection, every point you must quote the literature and the percentage. That is how you differentiate from a simple postgraduate to a oncology postgraduate. So I think with this, and we come to end of the first masterclass of this session, and I thank everybody starting from our past presidents who have started this masterclass during the COVID, and we are doing it since last 3 years continuously, and to all our office bearers at present, the president, Dr. Dev sir, Sarath Bhai, Subbu sir, and Toprani sir, Arnab, and our chief guest, Professor De Cruz, who did a beautiful presentation of the lucid, with I think each slide was a short question. So I think that every slide and every line was so important in his talk. And also the SIBA did a very good job by putting the lead questions, and students, everybody. I think we thank everybody and especially the Indo-American team for continuously doing it for last 3 years, and we will be having more good generation of such type of discussions among the postgraduates, and everybody will benefit. Even I think as a senior also, you might get few of the points which might have missed before. So I think we must thank everybody in the preparation, and we continue to cherish the ISO master classes and the academics that is being going on since last 3 years. Thank you very much, everybody.
Thank you, Rudra. Srajan is held up because of some problem at home. So I was actually anxious because it's the inauguration, and then Anil De Cruz himself is here. So, but he trained two of our final year residents so well that
I know.
this went on seamlessly. You have Fani and Anuj here. They're brilliant kids. They're being well trained to become a very good surgical oncologist. I thank them for this effort. Thank you
Yeah,
very much,
I
all
think
guys.
Fani and they
Anuj.
did a very good job. I think Srijan passed on the baton very nicely, but due to some emergency situation, and we miss him, and we love to see him in the next master class. Some emergency, so he had to leave. But before he leaves, he communicated with everybody and sent the link, everything. Then he prepared both the boys to take over, and everything was seamless. That is wonderful, actually.
Thank you very much.
Thank you.
Thank you. Good night, Anil, Arvind, Shiva,
Thank you very much.
Rajendra,
Thank you, everybody.
and the
Thank
kids,
you, sir.
Richa and Pratik, all of you. Yes.
Bye. Bye.
Thank you,
Thanks,
both the
everybody.
students, Richa and Pratik. Thank you very much.
Thank you all. Good
Anil
night.
wanted to say something. Yeah. Thank you.
Bye.
Thank you. Bye-bye.
Bye.
Good night.